we think of arthritis in orthopedics, what we typically think of is the wearing out of the joint surface. And in the knee, there are really three separate aspects or compartments of the knee joint that we think of. We talk about the femur, or the thigh bone, at the end, and the tibia or shin bone, and that has cartilage on it that we call articular cartilage. That's the coating cartilage, if you will, of the bone. And those cartilages rub together, and in addition there's the kneecap or the patella that slides through the end of the thigh bone. And so those three compartments are coated with this cartilage that can wear out. And much like the tread on a tire, the wearing out of that cartilage is what we usually refer to as arthritis. The most common type of arthritis we see is degenerative or wear and tear arthritis. And wear and tear arthritis, again, is literally the surface of the joint just slowly erodes from friction or wear and tear over time, much like the car tire that's driven for 60 or 70,000 miles. And there are other types of arthritis that are certainly less common, but we see them frequently in our office just because of the volume that we see. We oftentimes see inflammatory arthritis from patients who have things such as rheumatoid arthritis, Sjogren's disease, lupus, or other types of inflammatory or autoimmune diseases. And those eat the cartilage away in the joint in a little different fashion, but the end result is typically the same. The surface of the joint is worn away. Another type of arthritis that we'll often see is post-traumatic arthritis, or arthritis that comes from an injury which either the joint is disrupted or the cartilage is directly injured from a blow to the knee, say a car crash or a major sports injury, or we'll see injuries to the cartilage from fracture where the cartilage is disrupted or the alignment of the joint is changed because of an injury to the thigh bone, the femur, or the shin bone, the tibia. Almost always, the main symptoms of arthritis are pain. And so we see patients who come into the office complaining that they have pain in the knee. They'll often complain of stiffness, and sometimes will complain of loss of function or swelling in the knee, but most typically we get complaints of pain. As patients have arthritis symptoms that progress, oftentimes we'll see pain at night, and so many patients will complain that they can't sleep. And once patients can't sleep, that really upsets them, and that's one of the things that typically will bring them into the office. If patients have done their homework, so to speak, and come into my office already having had medical treatment, they've tried anti-inflammatories, they've tried pain medication like Tylenol, they've used rest, or they've used ice and heat, they've seen their primary medical doctor, and they've done a little bit of physical therapy. We consider those the basic initial treatments for arthritis. If patients have failed those, they come into our office and don't feel that their pain is adequately controlled, then we can treat them with injections. That's oftentimes the next step in an orthopedic office, and there really are two types of injections. One, the classic standby injection, which is a steroid injection, a corticosteroid. The classic name for that is cortisone, but we don't really use cortisone much anymore. It's kind of the Kleenex or the Coca-Cola of injections, but we do use steroid injections frequently, and we oftentimes combine those with anesthetic medicines to give you some immediate pain relief. We can also use a gel-type injection called hyaluronic acid, which is made up of a special protein that's found in the knee, which acts like a gel and decreases some friction. It helps with lubrication, and it seems that it also can, in some ways we don't fully understand, help with inflammation. There seems to be some question of whether or not that's going to be a good, reliable, long-term treatment, and really whether or not we're going to use that in the future is up in the air. There are other injections called protein-rich plasma or platelet-rich plasma injections, which may have a place in the treatment of arthritis of the knee in the future, but again, the data on that is a little sketchy. We can also prescribe, obviously, prescription medications, but in our office I haven't found that prescription anti-inflammatories seem to do that much better than over-the-counter anti-inflammatories. Ultimately, if you fail physical therapy and medications and injections, then it's time to discuss surgery. And for knee arthritis, there are really two main options. One is a partial knee replacement, which removes the bone from one of the compartments of the knee, either the outside compartment, the inside compartment, which is most common in a partial knee replacement, or the patellofemoral joint, the kneecap joint in the front of the knee. And we replace the diseased bone, the worn-out bone, with metal and plastic implants on that portion of the knee. And if patients have very specific arthritis that's limited to one location, that can be an appropriate option. Unfortunately, there aren't a ton of patients who qualify for that for various reasons. And so we'll often move to a total knee replacement. And in a total knee replacement, we literally remove all the diseased surfaces of the bone. We have a vendor model here of what happens to a knee as it gets arthritis. And we don't usually see that the bone turns red, but the cartilage does wear off and it gets very irregular and bumpy. And basically we go in with special instruments and we remove the surface of the bone. And after we do that, we're left with bone that has cut surfaces on it. And we replace it with metal and plastic implants that act as the smooth, moving articular surface of the knee. And that allows you to move without pain. There really is no limitation to when arthritis can be treated surgically. There's data to show that patients in their 80s or even in their 90s who are active physically and who are medically healthy benefit from a knee replacement. There's so much morbidity and so many complications related to living with arthritis. Patients lose mobility, they require significant care, they can't work, and they get all kinds of complications from that it's been shown that a knee replacement really at any time is appropriate if the patients are healthy enough and active enough to get it.